Hello and welcome to my channel. My name is Peter Abraham. I am a second career registered nurse with extensive experience in hospice and palliative care. I'm also a prolific book author, writing a number of books, guides, depending on your terminology, for my fellow hospice nurses, for holistic nurses, of which I count myself as one as well, for caregivers, and for end-of-life doulas, sometimes known as death doulas or life transition coaches or guides. On this channel, and if you're new here, welcome, thank you for visiting. We talk about things related to death and dying. Death should not be a forbidden word. It should not be a stigma, because each and every one of us will die at some point in time. There'll be discussions from time to time from my fellow hospice nurses. I recently did a video on interdisciplinary team notes from the book I wrote on hospice documentation. There'll be videos talking about being a death doula. I've had a number of those, and that's actually going to be the topic of today's video. Specifically, a short as I can make it, and some of you who watch my videos might be laughing at my use of the word short, because I do tend to be verbose, but talking about care plans for end-of-life doulas. And yes, non-medical support personnel can have care plans. We'll have discussions on being a book author. We'll have discussions of what families and caregivers go through, such as anticipatory grief before somebody dies. So if these are topics of interest to you, please consider subscribing and hit the bell notification below. And if you like what you're seeing, please take a moment and just click that thumbs up button. It does help with the YouTube algorithm, and it helps encourage me just to put out more content like the one you're seeing now. So before I go much further, I know it just adds to the time of the video, but I strongly believe that we should ask ourselves every single day, what are we grateful for? So just looking over this past weekend, and yes, this is an impromptu video. I just published one for today for my hospice nurses dealing with interdisciplinary notes. But I'm grateful for my wife, Laura, who worked with me this past weekend. She set up my new office. She put up my Kentucky registered nursing license, my Pennsylvania license in the back. We started moving bookshelves over. I mentioned in a previous video, I moved to what was the guest room, but it's now the room that faces the yard this way, where I could just look out and see the beauty of our garden, and see the sunlight and everything else there. And I'm just so grateful that my wife is very patient with me. I have autism, and sometimes I have panic attacks, and oh my, but I don't want to go down that rabbit trail. But that's what I'm grateful for. What are you grateful for? If you want to comment and have a discussion, comment. This is a non-judgmental channel. So in terms of trying to keep this brief, I'm going to school to the International Doula Life Movement, IDLM, and I'm really enjoying it. We're heading to the last few weeks where graduation is just, I think it's the July 16th is our last class. I was almost tempted to say less than 2 weeks, but we're not there yet for 2 weeks. But it's going well, and we have the challenging aspect of developing a audio video case study. We were given 10 choices to pick from. We could do any one that we've dealt with in the past. They showed us example case studies that was done before. I'm doing something similar in terms of a retrospective case study of a patient that I took care of. One where it was one of the only ones where a family mentioned me in the obituary, so I feel comfortable, even though I'm altering some of the names, but I should feel more comfortable doing the case study from this perspective. And it was a hard choice. I had a large number of patients and families that I just literally platonically fell in love with that I wanted to do the case study on. But here's where it gets to the care plan. So when it comes to end-of-life doulas, we're non-medical support personnel. We don't do the heavy lifting per se. When I always talk about heavy lifting, I'm talking about the physical labor portion. Technically, we're not in there to give the patient a bath. Not saying we can't, but we don't have the same training of a CNA or a home health attendant. Our training is to support the family with they make the decision, but we support them with the information on how to make a decision for end of life care. That could range from advanced care planning, which is what do you want done when you can't speak for yourself? Do you want a feeding tube? Do you want a tracheotomy? Do you want to be intubated? Are you okay being maybe you don't want to be intubated, but maybe a tracheotomy would allow you to live longer. Maybe a feeding tube would allow you to live longer. Do you want those things? Me personally, I don't, but this is a personal decision. Some end of life doulas or transition coaches, we're companions throughout the entire journey. So we'll go visit I don't, this is where I struggle, client, patient, customer. To me, loved one means the most because I platonically fall in love with my fellow human beings. And I do use the word platonically because of the day and age that we live in, where there's a lot of uh, I'm not sure what words to use because I don't want to be offensive to anybody, but sometimes we let our eyes and our heart go in the wrong direction. And for me, and I'm not saying this to lift me up, I always want to have the point of view that you matter and I want your best interest at heart, allowing you to have the autonomy for you to say, not here, not there. And it's not Peter's way, it's your way when we talk about autonomy and not pushing my faith or belief systems on you, but sharing this is what I do. So as we moving on, talking care plans, for those end of life doulas or transition coaches that are they're spending more time in one way, shape, or form. And this could even be with the initial intake. You need to be aware of what you're walking into. So that initial intake, part of it might be an initial phone consultation. I have set up on compassioncrossing.info several pages will refer to, right now I'm using Calendly, might switch to TidyCal, right now trying Calendly. They'll go and set up, your free 60-minute initial consultation. But for my clients, my loved ones that live in Madison County, Kentucky, to the degree that I'm able and that they welcome me to come, I want to go there in person, still part of the free initial consultation, and meet with them and see hands on, am I going to be a fit? Am I going to be a fit? Can I be of service? How can I help? Continuing with the care plan. If we're going to be on site, and I'm not saying you don't need this virtually, so if you're doing this virtually, you might need this well. Well, my fellow nurses work with care plans on a regular basis. To some of us, it's a bane. Some of it's literally checkboxing to get the software off our back, so to speak. But there are time and place for care plans where they make everything extremely meaningful. When we talk about patient-centered care, part of the heart of patient-centered care is a care plan. How are we gonna care for this loved one? So part of the reason for this impromptu video, this discussion, is a fellow student of mine, and I really love IDLM. We have a dynamic cohort. I'm part of cohort 25, and if you're watching this and you're a member of 25, I'm not naming names because this is not a matter of saying who didn't know this and who knows this. This is a matter of supporting and uplifting everyone. And if you're a member of cohort 25, I am rooting and I'm backing you up. And if I'm able to help in any way, shape, or form, and I know you do the same for me, I platonically love each and every one of you. But here, getting back to the care plan. So I'm going to use my case study as an example. I'm using a case study of a loved one that I cared for. I still remember this person to this day. I remember a lot of my patients to this day. I admitted this person in early May. I literally forget if it was around the time of my birthday, but I know it was close. Glioblastoma. So my fellow nurses are going to know this, but this is part of the picture. This is part of the picture. And I have to think of a way to get this to you, my viewer on YouTube. But I have a gift for you. I have to think about how to execute the gift now. That's going to be the hard part. Me who did 30 years of IT, and now I have to figure out how to do this on my WordPress site. But I have a document that I created. And just give me a moment right here, because I am going to be giving it out to the visiting angels of Kentucky when I meet with them later this week. There we go. So thank you for bearing with me. But I have a document that it's only a few pages long, 3 pages long, that goes over, and just let me get here this screen so it can just focus. It goes over key risk areas around most common diagnoses. So key risk areas around most diagnoses. So if you comment below that you're interested in this, I'll work on getting you a free copy. Okay, we'll work through this. So here, I know with glioblastoma that loved one who has glioblastoma is at risk for seizures. So part of a care plan, it's 3 components. You have problems, you have goals, and you have implementation steps. You have problems, you have goals, and you have implementation steps. Now, the care plan is a living document. It's a living, breathing document. So when you first do your intake, your first time seeing the patient, you're going to be drafting, and I'm using the word drafting on purpose, you're going to be drafting a care plan. And when there's a change of condition or a change in condition, depending on your terminology, you're going to be reviewing the care plan. Do you need to change anything? Do you need to delete anything? Do you need to add anything? What do you need to update? There's not going to be updates at times. Maybe you have the perfect care plan. I'm not saying that to be facetious. Maybe everything's on target. But you have problems, you have goals, and you have implementation. So going through with my glioblastoma patient. Glioblastoma patients are at risk for increased seizure activity. Now, when we talk about this, I'm not talking percentage risk, and it may never happen. I've cared for a reasonable number of glioblastoma patients over the years, and I've only had one patient that had seizure activity. The others didn't, but they're at risk. So the problem is risk for seizures related to glioblastoma. So risk for seizures, and why are they at risk for seizures? Because they have glioblastoma. Now, what's the goal? Now, this is an area that mixes up people more often than not. And I'm talking when I say mixing up, it mixes up nurses and it mixes up non-nurses. How can you reduce the risk? It's not like, now I believe in the power of prayer. And I know there are people out there that believe in magic. I'm not saying I'm one of them, but it's not like you have a magic wand. And as much as I believe in prayer, I do believe God is always supreme and God is not a vending machine. So I can't say a prayer and it is guaranteed to happen because Peter said it. But the goal, when you're working with somebody at risk to have for seizure activity, is to reduce the risk of seizures. That's one goal. And the other goal is to reduce the risk of harm if he or she has a seizure. So those are your goals. So how on earth are we going to implement steps to reduce the risk of seizures to ensure that our goal is closely matched as possible? So in this particular case, and please pardon me as I go and I look, because my short-term memory, if you watch some of my other videos, I suffer from having short-term memory as bad as a butterfly. Not that I've ever measured a butterfly. So I'm using a software package called Dolato. DOULADO. And we get that 6 months at no charge, thanks to the International Life Doula Movement. That's one of the benefits for being a student. And it's very economical once you're done with, the trial period. So here, in terms of interventions that I came up with, I'm not saying, if you're a fellow nurse watching along, it's okay if you have different, and if you have better interventions, please share them. This is not a competition. This is a collaboration to help lift everyone up so that we all grow. So I have here that I'm going to educate the patient, and I use patient because I don't know the neurocognitive state at this point in time. So I'm going to educate the patient and all involved in the care of the patient on how to identify a seizure. Now, for me, I can do this because I've had so many patients with seizures. I know that there's grand mal, petit mal, absent seizures. I know about the triggers for seizures, and if you work with somebody that has seizures often, you can sometimes see they're going to about to have one. So I'm going to teach everyone involved how to identify, and I'm going to teach about the different types. I'm going to teach about how to manage safety with the seizure, such as, make sure that there's nothing in their mouth, and don't put your fingers or anything. And I just so you know, what I mentioned in previous videos, I'm broken. I make mistakes. I still remember to this day when I think it was either a teenager or pre-teenager, I was accredited for a point of view for saving my brother's life. Uh, I happened to be going to the bathroom, and he happened to be, I don't know if I was in the shower and he was going to the bathroom, or I was going to the bathroom and he was in the shower. This was many years ago. I'm 62. This is going back many years. But he ended up having a seizure, and thankfully I did not lose my fingers, but I made the mistake of putting my fingers in the mouth to try to prevent him from swallowing the tongue. Good idea, wrong implementation. So, but here you would teach your caregivers and the family, this is what you do. You'd educate them. You educate them on post-seizure activity, that post-ictal response, like they're most likely going to be incontinent. Even if they were perfectly continent, they're going to have an accident, more likely than not. So they're going to need to be cleaned for not only for dignity's sake to protect their skin. Uh, you're going to go through your safety checks with them. You're going to get their vital signs afterwards if you have the capability, comfort level, and training. So some of this, keeping in mind, non-medical doula, you may not be able to get vital signs, but you're going to tell the other caregivers that are involved in this, we need to get a set of vitals, and this needs to be documented. And then you're also going to be ensuring before the seizure happens. So if they're at risk for seizures, are there medications in place? So if this loved one is already on hospice and or palliative care, I'm going to be asking, are diazepam, Valium suppositories in the home? Is it part of the comfort kit? I'm going to be checking that and ensuring that's in place. And I'm going to be educating the fellow, making sure does everybody know how to use these? Because you don't give them, right, like, oh, he's having a seizure, let me give the diazepam suppository. Those are typically given at a certain point of time because there's a safety risk involved for all, and you have to manage everyone's safety risk. So this is part, I know this as a nurse, you may not. And part of this, as you're going through this, if you're an end-of-life professional, I am not sharing this to scare you, because if you're hearing this, oh my word, I'm not yet trained at that. The key words is you're not yet. You are not yet trained. Not that you can't be, not that this is a roadblock, not that you should run out the door and that you can't do this for a living. You can do this if your heart is called to do this. If this is your dream, and maybe your dream is, maybe you're reading my Becoming a Death Doula book, Foundations in Practice. That's book number 1. And there is a combined book that's 8 and a half, 11, that has the foundations in practice, business growth. Maybe you're signing up to go to the International Life Doula movement. Maybe you're going through another school, but you're not yet trained on some of what I'm bringing up. That doesn't mean that you can't learn. That doesn't mean that you can't comment below and ask questions so that we can work together, because to the degree that I can help you for free, I will help you for free. If it gets to the point where it's a little bit too much, it might be, you know what, this is turning into consultation, but I'm not going to trap you. That's not who I am. I'm trying to help everyone that I can, both remotely through YouTube and on-site Madison County, Kentucky. So moving on with this case study, there's going to be three more. So if you're watching this and watching the time, there's three more. So for those that have glioblastoma, and I've had almost every glioblastoma patient that I've had this happen, their increased risk for falls due to decreasing visual acuity secondary to glioblastoma. Now, by the way, if you're a nurse and I'm using this related and secondary incorrectly, please comment below. I struggle with this as to the order of things, and this is not I got to pass an exam. I'm not saying I don't want to learn the right way if I'm doing it wrong, but please comment down below. But if they have glioblastoma, they're at increased risk for falls because their visual acuity, they're going to have trouble seeing. Their blurred vision is very common. Double vision, blur is just increased risk of falls. So the goal is to reduce the risk of fall and minimize harm. So the implementation, we're going to remove fall and trip hazards. We're going to ask the partner and the family to install grab bars in the shower if they have palliative and hospice care involved. And before I forget, what if palliative care and hospice care is not involved about the seizure? What if they're not involved? Well, I'm going to call their doctor. I'm the end of life doula, may not even use those words. And this is part of why with IDLM, they really promote getting the dual liaison form signed. I can't show an example because I don't have a printout, but it's just a permission form and a HIPAA form signed, even though technically we don't fall under HIPAA. It's best practice that we get all these release forms signed so that we can communicate with the provider and say, I'm involved with the care team. This patient's at risk for seizures. Can you please write a prescription? And communicate this with the family. Don't do this behind the family's back, please. Please. May have a good heart if you're calling the doctor, but say to the family, because the reason why is this costs money. Their insurance may, if they're not on hospice, will cover the seizure prevention, or I should say, let me word this. Diazepam suppositories, Valium, lorazepam, Keppra, levetiracetam, if I'm not killing the pronunciation too much. These medications reduce the risk of seizure. There's nothing that is guaranteed to prevent the risk of seizures. And I word it that way because we, especially in Western medicine, we put too much power into medicine. There is not a medicine on the planet that will guarantee a person will not have a seizure. There's medications to reduce the risk. So you want to let the family know there's medications out there. Could I call the doctor for you? Maybe you want to do it for yourself. And here's what to ask for. And talk to the doctor about it, but involve them. So getting back to the falls, you're going to ask them about the grab bar. If they're on hospice or palliative care, they could probably get DME ordered like a shower chair. And then you're going to go over about educating on fall risk assistive devices. And then if somebody is fallen, how to assess before you even get them off the floor. I was sharing with somebody the other day. Oh, I remember last Monday, I was a companion volunteer, and the patient's family member was visiting from out of state, and she's also a registered nurse. And when I told her this is I don't know how to word things, but this is why it's so important never, ever, ever to assume things. So we were having conversations about what we went through during COVID, and while we saw things from a different perspective, uh, what I shared with her that when I worked at Manor Care Kingston Court in York, PA, that a nurse had to assess, a registered nurse, and they wanted this to be the RN supervisor. They had to assess before they got the patient off the floor. On their end, initially, they were livid. What do you mean they have to lay there on the floor? Let the CNA get them up. Let the LPN get them up. Why are you letting them lay there? And then when I shared, we have to assess if they broke their hip, legs bilaterally equal. She had the aha moment. You don't assume it's safe to get them up. And again, if you're an end of life doula, I don't know, I'm all alone with the patient. I don't know. This is where you work things, preferably before you're in that situation. And just so that you're aware, when I say work things before you're in the situation, I'm not trying to scare you because we can't plan it all. I still remember the case where I walked into a situation that no amount of training on this entire planet would have prepared me for. And I had to take that breathing moment and say a prayer to Jesus and say to myself inside my head, God will help me through in one breath and one moment at a time. If this is your dream, don't run away. Ask and work through. Give yourself grace, mercy, and forgiveness as much as you pray and ask for it for others. So work through. Keep moving. And I'm almost done. There's 2 more to go. So I have fatigue related to, so anyone who has any type of cancer, not just glioblastoma, if anyone has cancer, cancer fatigue is unbelievably and extremely rare. So fatigue related to glioblastoma and medications. So almost every medication in a hospice comfort kit, the opioids, morphine, oxycodone, any narcotic medication, fatigue, any anti-nausea medication, fatigue, any anti-anxiety medication, fatigue. So you have fatigue from the disease and you have fatigue from the bed. Talk about a double whammy. Or if they're taking several meds at the same time, triple, quadruple whammy. So what are we going to do? We're going to, we need, the goal is to increase the quality of life by reducing the impact of fatigue. So how do we do that? And again, if you're a fellow nurse and you want to add to this, please comment down below, non-judgmental channel. So 1, you're going to break the caregiving task based on client preference. You're not going to overload the loved one who's terminally ill. You're to find out from them. This is the battle plan for now. And how I would do it, keep in mind I am a hospice and palliative care nurse. How I would do it is I would say, here's the master plan, and we're gonna float every day. We have this master plan that we'd love to do every day, and I need from you just a general guide as to how you want this broken up in general, and work out a battle plan. And then we'll have a mutual understanding. You are in charge, not me. So when I come to you on the next day, I'm going to ask, this is the plan, and I'm going to rely on you to tell me whether we're going to even skip something today or not, or move it to another area. But we're going to break up the caregiving task based on the client preference and doing it when the client has the energy. And we should also be aware who's visiting that day and to what level of importance it is for that client, your loved one that you're caring for, to interact with that visitor. Because maybe they're going to need all that energy for that visitor or that event. Or maybe you or the hospice provider, somebody's doing a legacy project and they need that energy. So that you're going to ensure breaks when the patient can spend quality time with the visitors. I just mentioned that. And then also, even though I mentioned about quality time with visitors, you're gonna find out, this is why you want to find out which visitors matter the most to the patient. This is not discrimination. This is their journey. This is their journey. So they have the right to say, I want more time with this person or less time with that. And so for those visitors that they just don't have the strength, you're going to just have to do a balancing act. Remember, if you're an end-of-life professional, you're an advocate. You're an advocate. So last item, risk of aspiration pneumonia, aspiration at large. So everyone who is terminally ill, this is not just for my cancer patients, our cancer patients. Everyone who is terminally ill at one point will lose their gag reflex. It's part of dying. It's at greater risk for anyone who has cancer in the brain, lung cancer. They're at greater risk. Any of your dementias at greater risk. So the goal is reduce the risk of aspiration pneumonia. So you're going to educate the caregivers and families on signs and symptoms that you need to progress the diet. Regular texture. Regular texture is anything on the menu. Nothing is limited from their choices. I don't know how they're going to fit that in their mouth. That's regular texture. There's no rules or regulations on regular texture. Softer foods, like softer foods, like your pastas, your spaghettis, your lasagna, depending on what's in it. Your softer foods. And when you talk mechanical soft, that's where either with a fork or a knife or a blender, but you're just gently cutting it up into smaller pieces. And then pureed, where it's like a pudding type texture. Um, and then on the liquid side, when you talk about thin liquids, we normally don't use that word in everyday language, thin liquids, but your sodas, your water, your energy drinks, those are referred to as thin liquids. But when you start acting medical grade thickening, which is literally cornstarch, the majority of the time, you have thin, then you have nectar thick, which is like molasses. It pours rather well. Uh, and that's because the throat has trouble. And I'm not saying you give this when they've lost their gag reflex. I want to be very clear. They lost their gag reflex, they're NPO, nothing by mouth. But as they're going through and you're reducing the risk, they're having trouble swallowing. Sometimes they're swallowing too fast, and that's part of why you're thickening the liquids to make it go down slower in a more controlled manner. So you're going, nectar thick is molasses. Honey thick is literally as thick as honey, so like goes really slow. And then pudding thick is like that blizzard from Dairy Queen where you're going like this and it's like not even coming out. Uh, I have not had a single patient in my entire career who tolerates, they like it, they just let it aside. They'd rather be dry as anything because it's so ugly to go through. And that's where a lot of education with the family. And so you're educating the family on this, educating on the proper positioning for the patient. Don't do this, don't do it while they're asleep in terms of giving them something to drink. I mentioned don't do it if they've lost their gag reflex. And you're documenting. All this is involving documentation. So we're coming to an ending. So if you're an end-of-life professional, even non-medical support, these care plans allow you to be aware of the risks of what the patient may be going through, your loved one, what the risks are, what the problems are, which are your risks, what the goals are, how do we minimize the risk or improve quality of life, and implementation. It's a living document so that as you're going through the journey with your loved one, you're reviewing the care plan. For instance, if they're NPO, I don't know if this is going to be the best example, by the way, but if they're NPO, they're not at risk for aspiration anymore. At least the risk is really reduced. If they're completely bedbound and they're a comatose state, are they at a risk for falls anymore? If they're actively dying, let me be extremely clear. They're actively dying. They're in a comatose. They're in the middle of the bed. Now maybe I'm making things too strict, but the risk of falling is unbelievably minimal. Maybe you end up taking that off. But I was sharing with somebody today in the movement, that's the social media group that the International Dual Life Movement uses, that maybe you didn't anticipate, maybe you didn't even know they had dentures, and you find out they had dentures and they fell out because they're losing weight. So you got to adjust the plan. So that's it for today. I do appreciate and thank you for your time. Again, if you like this, please like in the hit the like button. Comment if you have questions. If you want the document that I mentioned about for common diseases, and just so that you're aware, if you receive a copy, I have yet to see diabetes listed as a primary arterial diagnosis for anybody on hospice, and it's extremely rarely related to why somebody's on hospice. I've seen it if they've had pancreatic cancer, and it could be, of the adrenal glands for cancer. But I do have diabetes listed because there are risks that we need to be aware of as end-of-life professionals. But if you comment below, hey Peter, can I have a copy of that? We'll work together for me to how to get you a free copy. For that, it might be just getting your email address, and I will get that out to you via email. So thank you so much for your time. Take care, and God bless.